Hello, everybody. Welcome to a Tuesday VMR. We have the pleasure to discuss a case that's going to be presented by Kushal. And I have my dear friend Kirtan, after a long time, who is on his first day of his week off from work, join us for co-discussion. So I'm excited to just hear some words of wisdom from him on on a fantastic Tuesday cold morning. Hope everybody's warm. We kind of have what is this polar vortex coming in from the north in Canada on the East Coast. So everybody's kind of chilly on the East Coast, but hopefully we warm up with this fantastic case by Kushal. So I'm going to just let first Keaton unmute and just introduce himself again, and then Kushal, and then we'll go to Magnus and Eugene, who are helping us with teaching points and scribing. So you're up, Keaton.
Perfect. Well, good morning, fans. Thanks for joining. I'm so excited. And we always say that how time flies. That I remember that a few years ago, I was talking to Dr. Singh as a medical student. I was like asking him to give me tips and insights, like how to interview, how to perform well. And then today we are that I'm an attending, and I was asking Dr. Singh that how is it like to take the interviews of other candidates like me, right? So it's always a beautiful journey to see like how far you have come in your life. So like maybe that's what we should do once in a while, right? That just take a moment and see that how much we have grown with the help of others, right? So I'm excited for today's case, and Kushal always brings like very fancy cases with like bunch of imaging stuff and mysteries. So I'm looking forward to it. Kushal, how is your day going in clinic today?
Oh, it's been amazing. I couldn't have asked something for better, and so excited to be with you guys and make it even more better and memorable.
And hello
Awesome.
everyone, my name is Magnus. I'm from Denmark. I'll be scribing today.
Awesome. And Eugene,
Hello.
teaching points. Go ahead.
Yeah. Hello, everybody. I'm Eugene, and I'm in Ghana, in a very remote area with poor internet, but I'm happy to be here to join my online fun.
Yeah, appreciate the both of you for doing scribing and teaching points. It really helps us with this platform. Without both of you and also Keaton and everybody else, we wouldn't be able to do what we do every day. And stay tuned tomorrow. Bagdis will be co-discussing with Charmine, so do log in for that and give him some support. Okay, let's kick things off, Kushal, with the first aliquot. And Kirtan, you can start with the first aliquot.
I did ask Keaton what he felt like discussing, and he said anything is going to be fine. So I have a 73-year-old male a female who came in complaints of shortness of breath, and so she had it for the past 3 days, and also leg swelling for the past 3 months.
Perfect. Well, this is a good place to stop and reflect that we are dealing with a lady who is presenting with acute onset of dyspnea and lower extremity swelling. Now, always, what are the two main elements which we discuss in discussion for any case, right? We talk about the time course and we talk about the organ systems which are involved, and then we interplay those two factors to decide that what can be your differential diagnosis. And so far, we are hearing that this is an acute onset, but as always in medicine, that you want to clarify the events that is this something which is acute but has happened in the past? So then we would label it as like recurrent episodic presentation versus is this literally the first time and has never happened before, right? So those are the two different things. The second aspect can be that maybe patient feels that all these things have been going on for past 3 days, but what if you ask the family members, and if you ask them in detailed manner, maybe you will find out that patient has been having some swelling slowly building up for last 2 weeks, but now over past 3 weeks it has been so noticeable, or maybe it ended up causing disruption in their daily life, and maybe that's why they are coming, right? Same is true for dyspnea. Is it possible that maybe they were having dyspnea even 2 weeks before while they were walking, but maybe it was only present after like 1 or 2 blocks, but now they are so dyspneic that they can't even speak full sentences, right? So these are the caveats when we look at the time course, that often, let's say when we are looking at the notes, we are providers in the hospital medicine, and let's say we look at the notes from people who have seen the patients before us, you might see the one liner. Let's say 100-year-old lady with 3 days of dyspnea, And immediately you will be pivoting to that point that, okay, this is acute onset dyspnea. Let me build up my differentials. But always go back to the bedside and clarify that is it really 3 days or is it 30 days? And now 3 days is just what we are thinking, right? So that is the first thing I will say. And then second is once we have clarified the time course, what are the organ systems which we are dealing with? So if it was just lower extremity edema, the differential could have been so broad. You could imagine that apart from the vital organ systems being involved, like heart, liver, and kidneys, it could have been just like immobility, maybe obesity, associated venous stasis, and whatnot, right? But the reason why this case is more than that is because of the dyspnea, right? We always talk about that. Is it just discomfort? Leg edema is discomfort versus dyspnea, which is dysfunction of your organ system, in this case, the lungs, right? So this makes us concerned that whatever is the process has reached a certain tipping point that it is kind of overwhelming your pulmonary vasculature, and that is why it is causing some kind of dyspnea. So that's why I will be scrutinizing these two domains very closely. What's the time course? What's the organ system which is involved? And then we can build our differential. What do you think, Dr. Singh?
I think absolutely. What's interesting is like you mentioned, it's acute. So what can happen in 3 days? So something just rather than ramping up over, say, 3 months, what ramps up over 3 months? Maybe something that targeted one of the organs that are involved that we're going to explore further. Or it could be something like fluid ramping up. Although 3 months is a long time, people usually will present much earlier, say there is congestive heart failure. I mean, system one thinking, everybody that is listening to this case probably is thinking like, oh, this sounds like CHF because lower extremity edema and there's dyspnea. This has to be overwhelmingly a cause of exacerbation of heart failure. But what I usually think with somebody this age, is this linked or is this two simultaneously occurring events? And at this juncture, it's hard to say. But if I go further down the rabbit hole, the sister one thinking, leg and breathing, PE is one that you don't want to miss. And it's one of the most common presentations that does actually get missed because it can be very atypical, but this would be a typical manifestation with lower extremity edema. Although you might think to yourself, hey, usually DVT, lower extremity DVT culminating in PE is usually unilateral, not bilateral. But what kind of conditions would you get, like a bilateral DVT resulting in pulmonary embolism? If somebody has a high propensity to develop thrombus, like maybe malignancy, like a prothrombotic disorder. So just kind of exploring this space, but at this juncture, I think it's important to get a review of systems. That can be very powerful. As review systems, more data will actually shifts your pretest probability towards that 80% medium threshold, at which point your treatment threshold will be initiated. Do we have enough information to say, do we deploy Lasix in this patient at this juncture? Probably not, but having more review of systems will help. Say this patient has orthopnea, PMD. He has a very strong likelihood ratio, which will take your pretest probability higher and higher towards CHF. But at this point, I think we kind of mentioned quite a bit, but I'm not going to really move into diagnosis at this point. We'll ask Kushal for more data. Back to you, Kushal.
I think that's amazing discussion so far. And so I would just add, like, what the patient would have to say is that 3 months ago, she was apparently normal. And then what happened was, so she had to, they had placed her on AV fistula was created because they planned to start her on dialysis from early next year. So and then since then she has been on regular follow up with the vascular surgeon to make sure that the fistula is functioning good. And she has been at home and she is known to have asthma, hypertension, and CVA in 1986 due to use of cocaine. And she's also had a history of hepatitis C virus and was treated in 2015 and has a past history of ethanol use. But she endorses that she stopped or she quit about 3 years back. And Like I mentioned, 3 months back, she had the fistula created, and because she had an history of asthma, she was using the pump for the past 3 days when she started having shortness of breath, but it persisted and it wasn't helping her in any way. And it was getting worse as well, but she denied any chest pain, palpitations, or her baseline, she uses 2 pillows. So she said she's always used to pillows, so we couldn't really assess whether there's a worsen, but there is no worsening of orthopnea. And no history of travel, except that the previous day prior to this presentation, she did have one episode of PND in the night. And yeah, those are the other rest of the history we have so far. And did you want me to stop here, or did you want me to also give you the rest of the social history and family history?
Yeah, I
No,
think
I think, yeah, that could be fine, Kushal. You can give us the rest of this.
Okay, so her drug history, like no history of currently she isn't using any drugs. And from the chart, we could see that she had an episode of in 1986. She had used cocaine and heroin use. And she had a CBA which left her with a little bit of weakness, and she was with wheelchair. But with rehab, it's become better, and now she walks with walker. And personal history, also she did. She's mentioned that she quit alcohol about a couple of years ago, and she lives with her grandson. And on physical examination, she was in mild distress and she was wheezing. She was tachycardic with a heart rate of around 101 when she came. But later on, when they checked, it subsided to about 84, which was like the baseline we have on the chart for her. And then the rest of the examination, what I have is that so she also yeah, so she was wheezing and she was in mild distress and she was using a few of her accessory muscles. And on auscultation, there was also basal crepes present, and there was pedal edema, and abdomen was soft and obese. Neurologically, there was mild weakness persisting in her lower extremity, which they attributed to her CVA. So I'm going to stop here.
thank you, Kushal. You're delivering this case wonderfully from the clinic and also through your phone. So kudos to you. And also jumping in to present this case at the last minute. So what's interesting, Kirtan, I want to sort of start exploring the space of like the physiology of this patient, right? At 73 years of age, why would a patient like this just rapidly decompensate versus a younger patient? A younger patient usually doesn't manifest respiratory wise with maybe heart failure. They have less cardiac causes, maybe more reactive airway disease, infectious causes. If there is cardiac issues, maybe more like myocarditis, things like that. They don't usually present with maybe like HFpEF, HFrEF. So with this patient, you have to start thinking of what is their baseline. So as you age, the tendency is the blood pressure tends to go up as you age, unfortunately. So stiffer ventricles tend to occur. You will get some sort of maybe a little bit on the HFpEF side, not necessarily, but in this patient, I kind of have a hunch that there may be a background of HFpEF, but an echo would be necessary in this case if you're thinking about lower extremity edema and just kind of eyeballing the exam and so on. We're worried about volume, right? And the kidneys are at play too. There's also less, if you think about the whole body in itself, there's less physiologic reserve to be able to compensate against excess volume, especially when the kidneys, we already have the background that the kidneys are not functioning. And this patient just got a procedure. When you have a system that's like this, at this age also, infection could also be another occurrence, and you tend to have less of a robust immune system. So you would have to start thinking about infections as well. And then Not to mention, like a patient like this, you see that long list of medical history. There's a high likelihood of polypharmacy and multiple medications causing or contributing to this presentation, such as lower extremity edema and calcium channel blockers. So you have to always sort of look over the medication list. We haven't received the medication list so far, but if this patient has history of CKD, hypertension on, there likely are a number of medications the patient's on, and who knows, we also have to ask if the patient is compliant with these medications, and this could actually result in the presentation of this patient. But yeah, that was just sort of a quick background on what is the physiology, why does somebody at this age have a high likelihood to develop dyspnea very quickly. You want to take then the rest of the social history and behaviors and maybe any of the past medical history that sheds light on what may be going on, and then we'll tackle the exam.
Perfect, sure. Thank you, Dr. Singh. And I agree what Dr. Singh is saying. He's kind of demonstrating that how we need to be meticulous when we are dealing with an older person who has multiple comorbidities. And along with the comorbidities come the multiple medications, and all of them can interplay in different ways and can lead to the syndrome which we are dealing with, right? So it's very important to take into account each and every one of those details, right? Now, first thing is that we will ask Kushal to clarify later that what are the medications, right? And why this person got CKD. Was it just like indeterminate cause of CKD, which can often happen in older people, that they maybe have some degree of hypertension for so many years and it would be attributed to hypertensive nephropathy or just age-related decline? So we want to know that why this person had ESRD and why the decision was made to create the fistula, right? And second thing is that we know that this person was a little bit tachycardic, but we still don't know the other aspects of their vitals, like how was their blood pressure, how were they saturating. So we will clarify that as well. But if we just take a bird's eye view of this case, then this is something which is not unusual, right? We see so many people who have end-stage renal disease, and you could imagine that once they have end-stage renal disease, their whole system is in disarray, right? They have so much fluid in their body, they have excessive salt and water retention, which will lead to the activation of like the renin, angiotensin, aldosterone system and sympathetic nervous system, both of which will end up causing adverse cardiac remodeling. And that is what Dr. Singh was suspecting, right? That is it possible that this person has some kind of cardiac dysfunction, right? And this is very important to understand when we're dealing with any syndrome, that often we think that we have like one-dimensional thinking that, okay, this person has edema, this person has dyspnea, maybe it is coming from heart failure. But then what Dr. Singh told us is that he is thinking of two dimensions. That what if there is underlying susceptibility based on the risk factors, and then something else happened from the top of that? That's why this patient is in distress. That's why we are dealing with two conditions, not just one condition, right? So in older people, it's very reasonable to think that maybe they have like some degree of diastolic dysfunction in their heart because of this kidney dysfunction. And because of the diastolic dysfunction, now they cannot handle any kind of fluids which is coming into their ventricles. They are so stiff, and that's why it is regurgitating back into the pulmonary vasculature. Now we have to figure out that why this would have happened at this point in time. Did something change recently? So that's why the importance of medication history. Let's say if we come to know that this person was on diuretics for like 6 months, and maybe they missed their doses in last 2 days. Very easy explanation, right? What if this person was on a bunch of hypertensive medications and maybe they missed few of them? And in people with ESRD, it's very important to realize that because of the excessive salt and water retention, the chances of high blood pressure are almost 100%. So you need to be on some sort of medications for sure. And what if you miss those medications? That is the concept which we sometimes see in hospital as like so-called flash pulmonary edema, right? That there is so much afterload in your heart that your heart cannot beat and you have diastolic dysfunction. So eventually you will put up all the blood back into your pulmonary vasculature, right? So that's why the importance of medications and vitals in synchronously. So we can figure out that why this person might have this syndrome, right? So my mind is exactly where Dr. Singh is thinking, that what is wrong with the heart? What is wrong with the pulmonary vasculature? What is the volume status of this person? And once we have figured out all these common things, then we can gravitate our mind to the significance of the AV fistula. That can AV fistula play an important role in this equation as well, because we know that AV fistula is basically connection between the arteries and veins, and it is kind of like a high flow fistula, because the whole purpose of AV fistula is that every time you go for dialysis, you want to literally remove their whole blood, like 4 or 5 liters, and then purify it and give them back, right? So when you are dealing with this much volume of blood, you need a big fistula. And whenever there is a big fistula, there can be so much shunting of the blood, that it can cause some physiologic consequences, which we can discuss if that is relevant down the line, right? So another important aspect in examination, which we'll clarify with Kushal in next report, would be that how was the fistula site looking like? That was the fistula mature? Was it appropriately enlarged, or was it too enlarged? And what was the bruit or thrill which you can auscultate on the fistula? So all these parameters will tell us that how this person might be behaving in this way. What do you think, Dr. Singh?
Absolutely. Listening to your discussion, it's like I put on 3D glasses and you're sitting in front of me, giving me all this learning. But I love the 2D. Why not kick it up a notch and do three-dimensional clinical reasoning? But yeah, this is interesting, right? Whenever you have a patient with their complaints or the presentation is surrounding a intervention, you always have to think about it, but it's 3 months down the road. That's very odd. You can have late presentations, but I was thinking like a lot of immediate complications would result in the patient presenting a lot earlier. Infection would be within the week, but the infectious risk is always carried, right? So even with renal failure and say renal disease, patient is immunocompromised. This patient is overwhelmingly immunocompromised because of age, because of end-stage renal disease. But yeah, it was kind of, I have not seen anybody, we do we have a high amount of patients with end-stage renal disease in my community here, and a lot of them get AV fistulas. But what kind of things do we see? We see bleeding, we see infection, never seen a volume, unless say it's a malfunctioning AV fistula. We've had patients, they keep coming back and we're like, they undergo dialysis, but they're not able effectively to remove volume. So they're getting an ineffective time or ineffective hemodialysis. It's because there may be a closure or stenosis in the fistula, so they're not able to remove as much volume. So they keep coming back with congestive heart failure. Overwhelmingly, I do get a sense there's heart failure in this patient. The patient is fluid overloaded. There's the legs, the PND, basal crackles, wheezing. Although heart failure, you don't really need to have, the lungs may not have pulmonary edema. You can have decompensation of any organ due to circulatory compromise, manifest as CHF. I don't see a JVP. It's helpful, but if it's not there, sometimes it could be due to the experience of looking for a JVP or the size of the neck. So if it's not there, it does have a good likelihood ratio to swing the diagnostic compass towards CHF. But overwhelmingly, I think with, like you said, the kidneys or the output for excess volume. So if I have Kirtan here and I infuse him like 5 liters of normal saline, his kidneys will sense, the receptors will say, hey, we got a lot of excess volume here, so let's open up the floodgates and autodiurese, right? So we have a very potent hormone in our body in the heart, which is AMP. As you get atrial stretch from excess volume, it will be increased, and that will sense and tell the kidneys to then diurese. Years ago, actually, yeah, we used to give AMP as a hormone fusion to diurese patients, but the outcomes showed a tendency towards increased mortality. But now what did cardiologists do? Actually, the researchers do. They then figured out you make AMP in the body itself, so why not stop the hormone that breaks it down so that you get all the benefits from it? So I think in this patient, definitely the idea is maybe end-stage renal volume overload. Here's the interesting layer to this case is, we kind of could be at a diagnostic dead end, and this hypothesis is gaining a lot of momentum. Could there be something else in the background, Kirtan? I guess, right? We always get, like you said, it's two-dimensional chess. We have the first dimension, what is in the background here? So we really need to explore that. Sometimes we hastily or readily, just like any patient, I always tell my interns, residents, patient comes with DK, patient comes with DK or alcohol withdrawal. Always think about, why is this patient going through this syndrome? What is behind the scenes that's causing it? So always look for the trigger. And here I think we have to employ this mode of thinking. Anything else before we swing the mic back to Kushal?
No, I agree with you, Dr. Singh. We will ask Kushal that what was this background of CKD, why it happened, and we will ask for the medications and vitals, and then with the basic labs, we can discuss more.
Sorry about that. So first I would start out with his medication list. He's having Tylenol as PRN, and next she's having albuterol 2 puffs daily and PRN, allopurinol. She takes 100 milligrams by mouth in the morning, aspirin 81 milligrams daily, budesonide and formoterol 1 puff as needed, and Symbicort 1 puff as needed. And she's having also Eptoin injection once a week. And she has folic acid, furosemide, hydrochlorothiazide, 25 milligrams daily, and methimazole, 5 milligrams, naproxen. She takes about once as needed, nebivolol 10 milligrams in the morning, and prednisone 20 milligrams orally, for 3 tablets for 2 days, then 2 tablets for 2 days, then 1 tablet for 3 days. So for the past week, that's the regimen she's been on for prednisone. Then simvastatin, she takes 20 milligrams daily in the night, and sodium bicarb 650 milligrams tablet 3 times a day, and she's on Bactrim double strength, and she's on thiamine 100 milligrams. I forgot to mention that she was diagnosed with also thiamine deficiency about a year ago. So she's been on thiamine since then, and there's no repeat of thiamine levels for her from then. Okay, and then the next part of the vitals, which yeah. So the next part is the vitals. Her blood pressure was at 149 over 92. And like I mentioned, her heart rate was 100 plus, and then it became 84. And her respiratory rate was at 18, and she was saturating like 100% in room air. And she was afebrile. So that is about her, the vitals. And the rest of the examination, so she was, her mucous membrane in the mouth was a little dry, and then her pulses, the strength of the pulses were normal, and then the AV fistula, the last note from the vascular surgeon mentions that the thrill and the bruit is present and it's maturing as good as they wanted to or expecting it to, and they do recommend that she comes back to them for another review in early next year before they start the dialysis. And the cardiovascular exam, it's in normal rate and rhythm, and heart sounds were, they just mention a murmur, but they do not elaborate on what murmur is present. And how, like I mentioned, there were wheezes and basal crepes. And yeah, skin was warm and there was no rashes, and her mood was normal. And she didn't have any line or extra line or IV line, and because they were not dialyzing her yet. She was still, it was in consideration and talks, but she had not yet got any dialysis. Did you want me to give you any basic labs?
And Kushal, just to clarify, do we know why she has CKD?
So they don't mention and elaborate, but they think it's due to multiple reasons. And one is our hypertension, which has been uncontrolled, and HCV, because she had that as well. A past medical history of HCV was there. And she's also, they do not elaborate, and they haven't got any renal biopsy.
Okay. And another question was that you mentioned in the medications this person was on naproxen, Bactrim, prednisone. Do we know why this was given? Like, did she have like gout flare or something?
Give me one moment. Let me just pull up anything.
Yeah, well, what's
Yeah.
interesting, Kirtan. Oh, go ahead, Kushal.
Okay. So that was something which was started her to couple of weeks prior when she had the gout flare. And she has a past medical history of gout.
And she's taking prednisone, naproxen, and aspirin together.
Um, those were all the medications which she mentions she has. It's been given to her.
Okay.
It's not like she puts them together in her mouth.
Got it.
But
Got it. I was just going to mention, yeah,
you
you
wouldn't
have
want to do that.
right. That is going to cause a lot of problems, namely gastrointestinal bleeding. So, having an NSAID plus steroid quadruples the risk for peptic ulcer disease, formation of ulcer, and then this patient will have GI bleeding. So another new problem. But so this is probably the history of meds that she's had, but maybe not taking all of them together. But like you had mentioned, Kirtan, she has problem with volume. Her kidney's not working. She's not anuric, right? Kushal, she's making urine.
She does make some urine, and that's why
Okay,
she's making her intake and output wise. She's been having a output, and that's why they haven't yet started her on the
got
dialysis,
it.
but still been on tox.
So it's interesting you have patients with end-stage renal that actually make urine, so they're not able to essentially filter out all the waste products, so they still build up BUN and can go into uremia. So these patients that make a significant amount of urine output don't usually come in with heart failure. So I don't know if you've seen Kirtan, like patients with end-stage renal disease that make urine don't usually come in repeatedly with congestive heart failure and volume overload. So as patients taking Lasix, they, uh, I guess, empirically put in this AV fistula with eventual conversion to dialysis when they make the call, or the patient trends towards needing dialysis. So the Lasix, I guess, is working, but something's happened now that the patient's now manifesting early. Is it maybe it's a time to switch to dialysis at this point? And what would we look for in the labs? One would be volume overload that's not responsive to the medications. The other would be looking at the electrolytes, and namely the BUN, and signs of uremia. I don't see signs of uremia in this patient, so there's no signs of any confusion, any asterisks in this patient. So at this point, it's more of a volume issue. Even the blood pressure is not terrible. Usually, when I have patients that come in that haven't had dialysis or have problems with the kidneys, the blood pressures are excessively high, maybe trending 170, 160 and above. 149 over 92 is not too terrible. If we're thinking of a high output fistula or high output cardiac failure, usually we'll have a wide pulse pressure, which we're not even seeing in this case here. So at this point, I think my earlier hypothesis that was generated, likely it's volume, but then also looking in the background, is there any signal of another condition that may be simultaneously occurring in this patient that could maybe actually be the reason why this patient is presenting like this? Any ideas, Keaton, before we go on to the labs?
Everything, I agree with the kind of uncertainty you're bringing it up. And to be honest, friends, this is what exemplifies maybe like 80% of admissions which you see in hospital, that there are so many things going on. You still don't know what is the real deal, right? Like imagine this person is on like 15 medications. Are we sure this person is taking all 15 of them? Because like who will prescribe NSAIDs to someone who has end-stage kidney disease? Like it just doesn't make sense, right? Like if you have like gout flare, you would give like one agent. Why would you give two agents all at the same time? And we don't even know how bad was gout. So this is what happens, that we get overwhelmed by the data we are seeing. But what is the actual objective evidence of what's going on? We still don't know, right? Like the labs are, we don't have labs. The vitals are looking almost okay. Examination, nothing like crazily jumping out to you. So all I know is still what I knew maybe like 15 minutes ago, right? That this is the older person presenting with leg edema and like dyspnea. That's all I know. I still don't know what is the real problem. That is why Dr. Singh keeps on using the word just the volume. He is also not, how to say, committing to a particular diagnosis, because that's how medicine works sometimes, that you want to clear the clutter which you are dealing with and want to focus on what's the real deal. So what will give us the highest yield moving forward? That is all I will talk, right? So I think we need labs for sure, because Dr. Singh elaborated that how if you have anemia because of this GI bleeding, all these high risk agents which patient is using, then anemia is one of the causes of why you can have dyspnea. Anemia is one of the causes why you can have decompensation of your heart failure when it is already susceptible. Like let's say this person already has some degree of diastolic or systolic dysfunction, and now you have severe anemia, you will go into the, like, you will tip over the edge and you will go into the florid heart failure, right? So getting the labs will be important mainly from the anemia perspective. Then labs will also be important because we want to know what's this creatinine doing, right? That what if patient's baseline BUN or creatinine is like, let's say 1 or 2, but now creatinine is suddenly 5. So maybe you are getting the hint that although patient was making urine before, but now they are not making. So in the labs, I am focusing on BUN, creatinine, and hemoglobin levels. And then in the objective imaging findings, we will right away need transthoracic echo to make any kind of progress. That where is the issue? That is it at the level of systolic dysfunction, at the level of diastolic dysfunction, at the level of valves itself, or at the levels of pericardium, right? So only when we have this much data, we can make more progress and we can get some clarity. So what do you think, Dr. Singh? Anything else that you would like to add?
Wonderful, wonderful. You're shedding light on this problem that we have. So a lot of diagnostic clarity there. Let's swing the mic back to Kushal. I think the labs may actually give us some insight on what's going on.
Amazing discussion so far. And just to make sure that we have enough time to be able to get to the diagnosis, I'm just going to go through the pertinent labs. And so her hemoglobin was 8.3, and hematocrit was 27.8, and then the BMP, the electrolytes were within normal limit. I mean, potassium was like about 5.3, and then BUN was at 72, creatinine was at 5.4, and glucose was at 13. So if I don't mention it, it just means it was normal. And unless and until you specify and ask for something, I would move on. Is that okay? Or okay. And her trop levels was at 60. And the next one, which they got, was at 57, and it plateaued at 57. So next, what they got was they got a chest X-ray for her, and for her imaging, the chest X-ray had showed it to be they read it as bilateral mid and lower lung field patchy opacities may represent a component of atelectasis or consolidation. Clinical correlation is required, and small bilateral pleural effusion, cardiomegaly with pulmonary vascular congestion and pulmonary edema. It's noted for her chest X-ray at this point. Did you want so I can give you also the EKG, which was done for her at that point. And so the EKG showed normal sinus rhythm and possible left atrial enlargement and prolonged QT at 506. And they had also done a Doppler for our upper extremity where the fistula was at. And it says that no evidence of any DVT, and the functioning and the flow within the AV fistula was good. And yeah, and then they add, yeah, these are all the labs. And did you want to see the echo as well? And did you want to take a plunge at that, or did you want me to stop?
Right. So, Kushal, we wanted to know that how much more data is still remaining, because we can time our discussion in that way.
I think the most important thing would just be to see the echo images, and either you or Magnus could share that, and then it would be just putting all the pieces together would be what would be important.
Okay, perfect. Maybe I can ask Dr. Singh. Dr. Singh, do you want me to share the echo?
I guess, yeah, I guess we talk about get the echo, and then you can start with this discussion.
Sounds good. So yeah, Kushal shared the echo with me earlier. I didn't get a chance to open it, but let me try.
I also have it here.
Oh, you
Thank you,
actually
Mohammed.
have the echo. Okay. This will be interesting. All right, go back and actually pause. Yeah, pause it there. If you can pause it, yeah. So a couple of things I'm seeing. So when you're looking at this, is the parasternal long axis. I don't know if you can, you won't be able to see my arrow, but at the top we see the right ventricle outflow tract, and then lower down we see on the left side the left ventricle, and then the opposite side left atrium, and then what's coming out of the left ventricle is the aortic outflow tract. So the first thing we look at is the valve. So the anterior mitral valve leaflet should, if you have good EF, it should actually kick the septum. So that means during diastole, the pressures in the left atrium are high, and then the blood is just moving through to the left ventricle. But if you have cardiomyopathy, the left ventricle and diastolic pressure and volume is high, so it's not able to accept much blood. So that valve really won't open up really like a lot to allow the blood to move into the left ventricle. So then LVEDP you can probably hypothesize is high, and this is one of the indicators that systolic function is low. Then you look at also the excursion of both walls of the ventricle. So you see the septum and the outer wall there not really coming together. Actually, play it again. Actually, there actually looks like there is good squeeze there. And then the third thing is you look at the ventricular walls itself. They do kind of look thin. So that could be another indicator of cardiomyopathy. But the valve, trying to see if it's really hitting. So actually, it's near, it's approximating. So to me, it doesn't look like it's like severe cardiomyopathy there. Yeah, it's not hitting it completely, but it's not really kicking it. So, but the excursion of the walls looks good. If you come down further, you see the hyperechoic structure there. That's the pericardium, and then we see the aorta behind it. And I don't see pericardial effusion really. No, I don't see any pericardial effusion. So, what was the read then? Do you have the read, Kirtan or Vishal?
Yeah, I just forgot to mention. Amazing read, Dr. Ravi. So her BMP was 27,294. That was her BMP at that particular point. And her read for the echo is, if you could play that again, you would actually see that the whole yeah. So sorry, I just got distracted for a second. So if you actually play it again, you can see the leaflet of the valve. It actually moves like a hockey stick. So, and apparently that's a sign called a hockey stick sign, and it's very characteristic for a history of a rheumatic heart disease and rheumatic heart valve. So the final read of the echo was that she seems to be having a normal left ventricular size, mild left ventricular hypertrophy with discrete upper septal hyperphony, sigmoid shaped, or that is the one which they said it could be a hockey stick appearance, left ventricular outflow tract obstruction at rest, but no dynamic left ventricular outflow tract obstruction with Valsalva maneuver. Ejection fraction was 60%, and the hockey stick appearance abnormality of anterior mitral leaflet without stenosis is for moderate and very eccentric mitral regurgitation is possible, suggestive of possible rheumatic mitral disease. So, according to the cardiologist, and then mild aortic regurgitation and mild tricuspid regurgitation and mild pulmonary hypertension. So, I mean, those were all the significant things which they mentioned from the echo. So what the cardiologist said was that she probably has an untreated rheumatic heart disease. And
So, oh, go ahead.
and then on top of it, of having the AV fistula created and having a thymine, first of all, a thymine deficiency and then an AV fistula created, it's just like brought her onto a CHF at that point.
So yeah, I was looking right into the EF, but yeah, you're right. That mitral valve leaflet, they look weird. It's looked like it has a little bulb at the end of it. So first thing I would have mentioned was, is it a vegetation or prior vegetation? Because a lot of times, like you said, a rheumatic heart disease, these these uh these masses that you get on the valve or thrombi that you get on the valve sometimes don't even dissipate. They just stay there, but they're sterile. If say you have endocarditis, infective endocarditis, as long as the vegetation is sterile, it's okay. It may stay there, it may get absorbed by the body. But you're right. I need to look at this configuration. Hockey stick looks very interesting. But yeah, I think because the patient's tachycardic, that there is kind of looking hyperdynamic there. But yeah, I couldn't really tell if the EF looked fine. It didn't look impaired. So it's not a HFrEF causing heart failure, but a hyperdynamic, and maybe like you said, the EF is a bit accentuated, is what, 60% somewhere around there. The walls of the ventricle really didn't look too thick, but maybe the septum, you're right. Yeah, I would have to look at it again. But thanks for bringing it. You haven't looked at echo in a while.
Yeah.
Any comments, Kirtan?
Yes. So, Dr. Singh, if you see, like, if you just take a moment and to see how we made the progress with this case, that right in the first, we are saying that maybe there are two dimensions, right? That this person has underlying susceptibility, and then on top of that, you have this volume overload. And that's why we were saying that we need to get rid of all this clutter. Like, this person has gout on bunch of medications like albuterol, like every single person is on albuterol in the hospital. Like, what am I going to do with it, right? So that's the issue, that once you get rid of the clutter, and if you just focus on what we have, it's the older person who has been presenting with like acute onset of dyspnea. So we knew that there is underlying susceptibility and something tipped them over the edge. So that's why we're saying that echo will be high yield, because we want to see all the structures. So we want to see systolic, diastolic, we want to see the valves and pericardium. And here we have the answer, that we have something wrong with the valves. Maybe that's why there was this murmur. And this phenomenon is similar to what happens in pregnancy. That if you remember that, what are the absolute contraindications of pregnancy? So it's the severe pulmonary hypertension, and one of the other one is like severe mitral stenosis, right? Because we know that when you have mitral stenosis, and pregnancy will cause associated volume overload and kind of vasodilatation, very similarly to what happens in AV fistula, that you have such rapid shunting of the blood that you end up getting like very low diastolic pressures. That is why Dr. Singh was saying that you would expect like high pulse pressure if it was like kind of florid high output heart failure, right? So AV fistula physiology is very similar to what happens in pregnancy. So you could imagine that how mitral stenosis is poorly tolerated in pregnancy and how it can be poorly tolerated in someone who has ESRD as well, right? And I guess that when this person was following up with the prior providers, they might have picked up the subtle murmur, but maybe they could have attributed it to the flow murmur because this person has anemia, and that's how it might have been missed. But if maybe we could have done POCUS earlier, somewhere in the clinic or in the ED, maybe we could have obtained this diagnosis earlier. But in general, for mitral stenosis, the management is not as straightforward as it is in case of like aortic valves, because replacing mitral valve or placing the mitral clip is very tricky. It depends on the age and it depends on the volume status as well. Because if you have like florid ESRD and if you have too much volume, no matter what clip or whatever you put there, you will have like functional mitral regurgitation. So the clip also won't work, right? So it's like very tricky decision, and sometimes you need to get like specialists involved, like the valve specialists or like the EP physicians to figure out what's. So, Dr. Singh, any other final thoughts on mitral stenosis? Have you seen this before?
I guess we do see it quite a bit. I think it's not directly the cause, I would say. I think we're creating the perfect storm here with the kidney, the fistula, the valve, because the patient's been compensating with this valve for many, many years, right? And this suddenly didn't happen, although you can get worsening of the mitral valve over this period of time. But I think the key is like at this age, would you go for a mitral valve replacement, or would you address the volume, maybe get the patient on dialysis a lot sooner, and then see what you have, then follow the symptomatology and see how things are. But yeah, with this, yeah, I think the patient just has, like we talked about, the setup. What is their phenotype at this point? What kind of things do they have? So it's sort of like you sprinkle a little bit of this and that. You have kidney disease, and now the patient's kind of pushed over the top and is not able to compensate having this valve. So yeah, like we had mentioned earlier, look behind the scenes, pull back the curtain, and see if there's anything else that could be going on. If in real time, say, what's interesting on rounds, we have patients like this, and we always think about high value care, cost effective care, like echoes, right? We always you're always getting this feedback from the ultrasound department, radiology, that we're doing too many echoes. But in this case, you have to employ, like, okay, management decision, or management reasoning. Should this patient get an echo? So you have to think to yourself, anybody coming in with new onset heart failure, anybody coming in with a new murmur, 3 out of 6 murmur, definitely should get an echo in this case. Any suspicion of structural heart disease, which could be ascertained from the EKG, there's a suspicion, high voltages, you have to get an echo. So there's certain situations where you must get an echo, and this one would be, you would, to move the diagnostic needle forward, getting an echo, and like Kushal had showed, this definitely did indicate what was going on behind the scenes.
Yes, perfect. And the final comment I would make is that, like, if you just think about the main walls of the body, like the aortic wall, the mitral wall, it's about the proximity, right? So, like, aortic wall is more close to the aorta. So that's why you tend to get more like strokes or more endovascular phenomenon from aortic wall pathology. Like, when was the last time you heard that aortic wall issues ended up causing severe heart failure versus when did the mitral valve issues ended up causing heart failure, right? So that's the issue, that aortic valve will more cause like strokes and CNS issues, whereas the mitral valve, since it is very close to the pulmonary vasculature, often the mitral valve pathologies manifest first in the lungs rather than in the other parts of the body. So like we have seen so many people who have, like, as in this case, rheumatic mitral valve disease, or sometimes people can have mitral valve tumor, like a small thrombus there, or maybe a atrial myxoma on the mitral valve, and that ends up triggering the heart failure. So it again, kind of makes things, put things into perspective, that it makes sense that mitral valve, since it's close to the pulmonary vasculature, it is more likely to end up causing heart failure symptoms compared to the aortic valve. So I'm glad that their team did the echo and they did like the meticulous reading of the mitral valve and the hockey stick appearance. And maybe we can ask Kushal that what was the final conclusion, what ended up happening with the patient, and then we can move to the teaching parts.
Yeah, amazing discussion. Yeah, so we did go back and find out she did have 5 pregnancies in the past. And then she was also having Graves' disease. I saw one particular note mentioned from 5 years ago where they mentioned that she probably has Graves' disease, but I couldn't really see any follow up on that or any management for that part of it. So the final diagnosis which we did have for her is the rheumatic heart disease, like most likely a rheumatic heart disease and congestive heart failure with post AV fistula creation, and also multiple factors like alcoholic liver disease we're not quite sure about the Graves, so we have given her an endocrine follow up to confirm on that, on whether it was it was just entered by mistake. So yeah, that was that, and I thought it was an interesting case because she was doing too really good for a rheumatic heart disease, if that was what she had, and she was compensating so good. But then I think there was a needle being tipped little with each factor or each incident, what do you call that, yeah, so each problem she was having, and then with the creation of the AV fistula, I think it just took the needle completely, and then she just went the other side. So I thought it was really cool too. And it was a new onset of heart failure. So we just managed her conservatively, and she's going to be following up with the cardiologist and the nephrologist and the vascular were trying to see if, like Dr. Ravi was mentioning, if they would have to start her dialysis way sooner than they anticipated.
Perfect. Thank you so much, Tushar, for bringing us a case and the images as well. Dr. Singh, any final reflections, or we can ask Eugene to share the teaching points?
No, I think wonderful job. I think two things: ask why heart failure, what's going on behind the scenes, and I really like what Kirtan mentioned. Why is the patient having kidney failure as well? Because causes have been missed. We just assume patient, oh, it's hypertensive nephropathy. Patient is diabetes, but sometimes other alternative diagnosis like myeloma I've seen missed in patients before. So two good things to think about in such patients. Thank you, Kushal. Wonderful case. I will remember hockey stick for a long time.
Perfect. Eugene, our friend, take us home. Eugene, are you in a place where you can share the teaching points with us? If not, then it's totally fine.
Yeah, I apologize. I'm just going to log out. Thanks a lot for discussing, and amazing job, Eugene and Magnus. And thanks everyone for joining. And I apologize. I just have to get to the floor. Thanks.
No worries. Thank you, Tushar.
Thank you.
Yeah. But Dr. Singh, looks like that Eugene probably maybe not able to share.
Hi,
Oh,
can you hear me?
oh, okay. Welcome back, Eugene. Are you able to
Yeah.
read off the teaching points?
Yeah, sorry, I just connected on my phone just so I can read it. Yeah. Oh yeah, just pointing it. So this was a fantastic case presented by Kuchal that of an elderly man with multiple vulnerabilities presenting with shortness of breath and then lower leg edema. What we were taught from the onset is that you need to clarify the time course. It helps you understand whether the physiology is of a sudden loss of oxygen delivery, or maybe it's an ongoing condition and then something might have tipped it off, so that you go looking out for clues. And then you need to investigate the background data. What does this patient already have? And why is this patient coming with this particular condition at the moment? Then also, you need to understand differences between shortness of breath at rest and on exertion, because it means the patient could be having this particular shortness of breath for a long time and was on exertion until it progressed to at rest, which could mean a chronic process that affects oxygen delivery over time. So Dr. Ravi added on that doing a system review is important to understand which organ system is involved, because the two main areas when you're thinking about shortness of breath, the time course and then the organ system involved. And so considering autopnea, PND, and also considering some other symptoms like a cough, fever, you could think about whether it's of cardiac origin or it's of the lungs, or you may even think about an anemia, or even of infectious cause. Then we looked at the leg edema, where various physiologies that could cause that could include volume overload. So when there's abnormal fluid accumulation in the interstitial space, or you could even have a hypercoagulable state that could be from a DVT, and that could throw an embolism to the lungs, and then you could have a PE, or even infection, cellulitis could cause that. Or you could think about other conditions that could be from low albumin, and so reduced oncotic pressures and fluid extravasation. Then when you combine it, differentials that can come to your mind could be pulmonary embolism, exacerbation of a chronic heart failure. You can also think about lung issues like COPD, or even exacerbation of an asthma, or you could even think about some metabolic causes as well. So we had these in the background, and so we went ahead to investigate why this patient could be presenting like that. And the age stood out. Dr. Ravi mentioned why an aged person could come with such a clinical picture. That's because as you age, you could have poor compensation for excess volume. Your ventricles could get thickened. And then also you have a weakened immune system. So you could think that this patient may be having a pneumonia and could be presenting that way. Then the other risk factors in this picture that could exacerbate this phenomenon was the background end-stage renal disease, or could we think about multiple meds and some are being missed? And then we also had to look at the vitals to understand the volume status. So then if we look at those things, then we can also consider the AV fistula. Dr. Ravi mentioned that it's not so common that they could come with a hyperdynamic states when you have a very good functioning AV fistula. So we looked into the background data, we looked at the other risk factors, and patient was not making urine, so we were quite concerned to look at the BUN and creatinine. And also, we noticed that some of the meds, could they be combining the prednisolone and the NSAIDs, which could make them very prone to bleeding in the gastrointestinal tract. And so, yeah, we were not sure if that was the cause of the anemia in this particular picture. Not much comments was put on that. And then we got our echo, which is something that you want to consider when you have symptoms of suggestive of new onset heart failure. And already from our examination findings, we had crackles in the bibasal glands, we had pit edema. Yeah, these were all things that should encourage you to do the echoes. And when we did the echo, we got to see that this patient's valves were thickened, and what was described as the hockey stick phenomenon. So the distal portion, the base is dynamic, it's movable, but the distal portion is taken, and that is suggestive of a rheumatic heart disease that has led to the stiffening of the mitral valve. So we end up making a diagnosis of this, but we still were thought that it's important to still consider other things, because how will the patient who is compensating well for his rheumatic heart disease and a poor valve all of a sudden just pop up with a new onset heart failure? So could it be that there are still things at play in the background, like our kidney issues and stuff? But Kuchal explained that it could be that this new AV fistula that was created increased the hyperdynamic states and then led to this patient tipping off into heart failure. So that is what I have for us. A lot of teaching, and in a session like this, it's quite difficult to write a lot because you keep listening and learning a lot of new things. So thank you so much for this wonderful session.
Thank you, Eugene, and thank you also, Magnus, for scribing, and thank you, Kirtan, if you're still around, for co-discussing. Absolutely real-world case with so many twists and turns, and appreciate Kushal for presenting this case. Have a great day, everybody, and tune in tomorrow for Magnus's discussion. Have a great rest of your Tuesday. Bye.